afternoon, everyone. I'm Dr. Niwin, cardiothoracic surgeon at Daya Hospital, Thrissur. So, what's happening new in cardiac surgery? So, there are developments made in different fronts in the cardiac surgery. Newer valve repair, valve replacement devices, new things done in heart transplant, newer heart assist devices like LVAD, RVAD, BiVAD. Then, long-term study regarding the choice of grafts, arterial, venous, etc. in CABG surgeries, and fine refinement of the conventional open cardiac surgery, that is minimally invasive cardiac surgery. So, as a newer thing which is well established and even available in our tier 2 cities like Thrissur, I will talk about and focus mostly on minimally invasive cardiac surgery. What are the scopes? So I am sure most of you won't be familiar with the conventional cardiac surgery procedures. So open heart surgery, OHS, means any surgery in which heart is open to repair or replace something inside the heart. That is like a valve or a atrial septal defect, ventricular septal defect. Considering CABG, the most commonly done cardiac surgery, that is coronary artery bypass surgery, is technically not a open heart surgery. It is basically done outside the heart. The coronary vessels lying outside the heart. So before the invention of cardiopulmonary bypass machine, there were some methods to do repairs inside heart. That was one common surgery that used to be done was closed mitral valvotomy, where we put a finger inside the heart, feel the mitral valve and do the valvotomy blindly for mitral stenosis. Then once CPV machine was invented, we are able to do open heart surgeries comfortably. Now, to understand about the cardiac surgery, there are mainly 3 steps that we do in an open heart surgery. One is institution of cardiopulmonary bypass. Since we are doing surgery on the heart, we have to divert the blood from the heart, and something else has to take up the work of the heart. It is easier to divert the heart blood from both heart and lungs together, both easier technically and safer for the patient. That is why we have a machine called cardiopulmonary bypass rather than a cardiac bypass machine. So the main part is diverting the blood using cannulas. We take the blood from the SVC, superior vena cava, inferior vena cava, give it to the machine. Machine will have a pump which provides kinetic energy for maintaining circulation. Then there is an oxygenator which will oxygenate and return the blood to the ascending aorta or any other peripheral arterial system. Then the second part is isolating the coronary circulation and giving cardioplegia, which is a cold high potassium containing solution to prevent cardiac injury during the ischemic time. Then third is the access to the heart chamber, where the actual surgery is taking place. So in 1950s, the heart-lung machine was invented. In the earlier days, the surgery used to have a bigger incision extending from nipple to nipple, called a clamshell incision. In a decade later, median sternotomy became the standard approach. So for people who are not familiar, this is how we usually do a conventional surgery, where a median sternotomy is done, pericardiotomy is done. This is the ascending aorta, and we will place cannulas in the ascending aorta to give the blood back from the cardiopulmonary machine. Then cannula inside the superior vena cava, then another one inside the inferior vena cava. So that is how blood is diverted from both heart and lungs altogether and given back to the system. You can see that still now the heart is still keeping on beating. Now the aorta is cross-clamped, coronary circulation is isolated, still the heart is beating. Now we will give some cold cardioplegia through the coronary arteries. And you can see once that cardioplegia has gone, the heart will stop, heart gets arrested in diastole, and we can proceed with the cardiac surgery. So this is a case of aortic valve replacement for a aortic stenosis. So the main fear factor about the open heart surgery, whenever people hear common layman people or even the non-surgery people, the fear factor is about open heart surgery is that we have to undergo a sternotomy, open chest. So definitely sternotomy has got some drawbacks, like it needs a longer time for recovery. But I can assure you that sternotomy is a perfectly safe thing to do. Even in high diabetic patients with HbA1c 10 or 15, it is not the diabetes or the hypertension or the hyperlipidemia which is cause issues for the sternotomy. It is the underlying metabolic derangements like if the patient is in a state of low cardiac output or under coexisting pneumonia, COPD, these are the things which makes actually sternotomy a high risk or challenging factor. Otherwise, undergoing sternotomy is not at all a issue. But even then, like any other branch of surgery, cardiac surgery has also progressed and now offering patients open heart surgery without a sternotomy. So, any cardiac surgery is done through small incisions without complete division of sternum can be defined as a minimally invasive cardiac surgery. The main surgical access methods we use are hemisternotomy, mini thoracotomy, and completely endoscopic surgery and robotic surgery. So, in order to make the incision smaller, first thing we do is take out all the cannulation part from the chest to periphery. So, to institute cardiopulmonary bypass, we use femoral artery and femoral vein. So that the connection to the patient, to the cardiac pulmonary bypass machine is removed from the chest side. Then when we need only small incisions just to enter the chamber of surgery so that we can avoid the sternotomy. So here there is a small incision made in the third interosseous space and aortic valve is replaced through that. Okay. So this is another method of MICS where whole surgery is completely done under camera vision, just like any laparoscopic surgery, undergoing a cholecystectomy or a hysterectomy. Bypass is instituted with a peripheral cannulation. Here are the same steps that I showed before. The conventional open sternotomy method is being done under endoscopic method. Here the aortic valve is incised. Switches are taken and a mechanical valve is placed. So only length of incision is decided by the size of the valve, which comes around 2 to 3 centimeters, and the valve is placed. Similar thing in a mitral valve replacement. The pericardium is opened, aorta, given the cross clamp and the cardioplegia, left atrium is being opened. The mitral valve, this is a case of rheumatic mitral valve disease, the valve is excised, sutures are taken. And here a TTK, Chitra valve is being placed inside the heart. So what the patient has is a small periolar incision and some port site incisions. Same thing when done along with the help of a surgical system like a Da Vinci or a SSI Mandala, that is called a robotic surgery, cardiac surgery. Now, not just the valvular surgeries or closing atrial septal defects. Now, the minimally invasive surgery is also had it made developments in the coronary artery bypass surgeries. There are mainly two techniques. One is the mid-cab, which is a direct undivision coronary artery bypass surgery procedure, and the second is the robotic, where a Da Vinci robotic system is assisting the surgeon. So this is an example of how a mid-cab is done, where we have specialized retractors through a small incision in the fourth or fifth space. Whatever done inside the chest part is same, even if it is a sternotomy or a minimally invasive surgery. We'll harvest the required grafts, and I will show you how so this is a graft being made onto the posterior descending artery. The white line is the artery. It is being dissected, arteriotomy is being done. So this is an off-pump surgery. There is no use of a cardiopulmonary bypass machine because the surgery is being done outside the heart and the patient is hemodynamically stable. Now a shunt is being placed inside so as to maintain the coronary blood flow during the surgery. And the grafts are being anastomosed using fine 8 or 7 protein sutures. And this is what the patient is left with, small incisions, and patient can return to work within 2 weeks. Same thing when done with the help of robotic systems, it's called robotic surgery. And there are some other conditions. Another important thing is not all patients present with same severity of disease in different systems. You know, there is 3-vessel disease. So when there is multiple grades of disease, always we can go for a hybrid approach where the lesser severe disease can be stented and the major disease can undergo a bypass surgery. So my take-home message is both cardiac surgery and interventional techniques are complementary. There is nothing like you can avoid surgery by doing that or this thing. Both has its own benefits and disadvantages. So always go for a heart team approach, cardiologist and cardiac surgeon taking a decision together and advising the patient. And nowadays, open heart surgery does not mean open chest surgery. It can always done by a minimal access methods. Thank you.